Everything going?
Present.
Councillor Crater.
Present. Present.
Councillor Easton.
Present.
Councillor Foster.
Just one present.
Acting Regional Chair Grant.
Present.
Councillor Encina.
Present.
Councillor Yip. Councillor Jordan.
I'm here.
Councillor Olson.
Present.
Councillor Rigby.
Present.
Councillor Seaborn.
Present.
Councillor Cisco.
Present.
Councillor Sorrento.
Present, clerk.
Councillor Whalen.
Present.
Councillor Witteveen.
I'm here, thank you.
And we have regrets today from Councillors Diodati and Kaiser.
Thank you, Madam Clerk. I'll now go to Councillor Bateman to read the land acknowledgement, please.
Thank you, Chair. Niagara Region is situated on treaty land. This land is steeped in the rich history of the First Nations, such as the Hattaway-Wendurong, the Haudenosaunee, and the Anishinaabe, including the Mississaugas of the Credit First Nation. There are many First Nation, Métis, and Inuit from across Turtle Island that live and work in Niagara today. The Regional Municipality of Niagara stands with all Indigenous peoples, past and present, in promoting the wise stewardship on the lands of which we live.
Thank you, Councillor Bateman. Are there any disclosure of pecuniary interests? I'm seeing none. We do have 3 presentations today, so we'll call on. So before I proceed with the presentation, I'll call on Dr. Kosmani to provide an overview. And if there's no objections to the committee, if we can hold the questions to the presenters until all 3 presentations are heard. All right, thank you.
Thank you, Chair. I wanted to quickly lay the groundwork before the next 3 presentations. They all work together. First year, we will have Lisa Panetta and Laura Walsh. You may recognize them as regional staff, but they are joining us today in their roles as project manager and co-lead at the Mental Health and Addictions Working Group, which is part of the Niagara Ontario Health Team, NOHT-ESON. They're going to share the broader mental health and how the broader mental health and addiction system functions, including various roles and organizations that contribute both at the provincial and local level. Within that framework, in their presentation, you'll note that Niagara Region is one of 12 community mental health service providers. So this presentation will serve as a response to the request for information regarding mental health and addiction service gaps made by committee at the February 10th meeting. And then after that, we will have Allison Chambers and Shelley Mousseau from Gateway Niagara, who are going to provide a presentation on the Heart Hub. And finally, following that, Candace Chambers from our mental health team and Dr. Rachel Lamont from our mental health team will be sharing an update regarding the Housing First Assertive Treatment Service. And as you noted, Chair, since the presentations all work together, if questions could be held to the end, that would be ideal, as some of the questions may be answered in the subsequent presentations or maybe better answered by a subsequent presentation. So hearing them all would provide committee that opportunity. And so with your permission, Chair, I'll pass it over to Lisa and Laura.
Welcome.
Thank you. Sorry, I'm short. There we go. Good afternoon, and thank you, Dr. Kosmani. Oh, can I? Oh, thank you. That's much better. Good afternoon. Thank you, Dr. Kosmani. Lisa and I are here today to provide an update as project manager and co-lead of the Mental Health and Addiction Working Group of the Niagara Ontario Health Team, Équipe Santé Ontario Niagara. For brevity, we'll refer to it today as the Niagara Ontario Health Team. Our objective today is to share our group's role in the local adult mental health and addiction system and highlight the collaborative work our members have underway to strengthen it. I'll begin by stepping back to provide some broader context on the system. At the provincial level, on the left side of the page, the Ministry of Health sets the overall policy, strategic direction, and funding parameters for the system, including through the Roadmap to Wellness, Ontario's mental health and addictions strategy. Ontario Health, next, in turn, manages funding and accountability and oversees quality of the system across the province. Locally, and this is where we come in, Ontario Health teams bring service providers and partners together as one team focused on the needs of patients, clients, and communities. Ontario Health funds and holds accountability agreements with both the Ontario Health team and the organizations that deliver mental health and addiction services. In our area, that includes 12 community service providers, including, as Dr. Kazmani mentioned, one being Niagara Region Mental Health, nine primary care teams, and one hospital provider to deliver mental health and addictions services. I'll now share a little bit more about the Niagara Ontario Health Team and what we're all about. We're not a standalone organization. Rather, we are a network of health and human service organizations working alongside patient, client, family, and caregiver representatives. The structure includes a central decision-making table, which you'll see on the slide, the planning table, that is supported by a range of subgroups focused on key priorities, including, but certainly not limited to, mental health and addictions. Ontario Health teams focus primarily on where people access care rather than where they reside. Our area of focus includes much of the Niagara region in the green. The exception is Grimsby, Lincoln, and West Lincoln, which are aligned with the Hamilton Area Ontario Health Team based on their care patterns. These geographic areas help guide planning and coordination, but they do not restrict where people can access care. People in Niagara, like all other areas of the province, can still access services in the community that works best for them. With that, I'll hand it over to Lisa to speak to our working group.
Hi, everyone. The Mental Health and Addiction Working Group includes about 30 organizations, as well as people with lived experience, and we work very collaboratively together with the resources that we already have within our system. So before I get into the work of our group, I want to recognize that there are other factors that we need to consider, such as income, education, housing, social connection, and other factors that have a huge impact on people's well-being. Excuse me, long before they interact with the health system. For example, the health system planning report that you heard about last month showed that mental health-related emergency department visits increased as levels of marginalization increased. And in Niagara, that gap is even wider than the provincial average. So while the healthcare system absolutely plays an important role, it can't address these challenges on its own because many of the factors driving poor health outcomes sit outside of traditional healthcare. So now let's talk about the work of our group, starting with needs-based planning, which was a research project that estimated the resources required for a community based on the needs of the whole population. Niagara was one of 6 sites across Canada selected to participate, and Dr. Brian Rush and Dr. Daniel Vigo led the project. We contributed by sharing information about the resources we had at the time so that the research would make sense for Niagara. The final report has been helpful in terms of where we should start our work, where we should focus, but there are some clear limitations that the researchers identified in their report, and they make the point that it's not meant to serve as a standalone resource. Earlier in the presentation, you heard Laura referring to a document called the Roadmap to Wellness. In this roadmap, the Ministry of Health promises to define the core mental health and addiction services for all Ontarians, regardless of where they live. And those core services should come with standards on how each core service should be delivered, so that people can be sure that they're receiving consistent, high-quality care no matter where they go. So the needs-based planning report identified 9 recommendations for Niagara, and it's publicly available. Building on that, the working group prioritized those recommendations, drawing on the needs-based planning report and also our collective knowledge of the local system. So following that, we agreed to focus our quality improvement efforts on the services you see on the screen. So mental health case management services support people with serious mental health concerns so that they can live independently in the community. Those supports range from individual case management to team-based intensive support. And in Niagara, there's only a couple of organizations that deliver these services. So as you can imagine, wait times can be a challenge, anywhere from 4 months to nearly 2 years, depending on the service. And we also understand that people may not know which service to access. Some people may end up on more than one wait list or connected to services that maybe just aren't the right fit for them. So a group of service providers decided to put their heads together and come up with a solution, which they refer to as collaborative intake. So there's no new process for professionals, there's no new process for clients. They can still access services in the same way, including through the Mental Health and Addiction Access Line, which is available 24/7. What's different is that the service providers are working together in the background, sharing referral information, no matter which door it comes through, and then collaborating to match people with the right service and making sure that people with more urgent needs are prioritized. Oops, sorry.
It's gone backwards. That's okay.
Okay, we're done.
Now to another one of our 4 priority areas, bed-based substance use services. Niagara, like case management, has a range of these voluntary, time-limited services for people who want to stop or less often stabilize their substance use. These include withdrawal management, addictions treatment, and supportive treatment, and we see addiction supportive housing as an important part of the same continuum of care. All of these services provide substance-free accommodation paired with supports, but each has a different role to play. As a result, they differ in setting, staffing, and the type and duration of service they offer. Together, they are part of a broader system of substance use care. For many people, other supports, such as outpatient services, are a better fit. Depending on their needs, people may access these services at different times, move between them, or access them concurrently. To move this priority forward, we brought a small working group together of service providers and key partners to identify opportunities to strengthen the system using existing resources. With the addition of the Heart Hub, which you'll hear more from in the next presentation, the group is now working with Heart to plan how we will work together to provide care for shared clients so they will be able to access the right care at the right time and move smoothly between different services. Sorry. The group's other priorities, got thrown off there, it doesn't take much, are day and evening treatment and coordinated access. One of our local day treatment providers is currently undertaking internal service changes. Once that work is complete, we plan to reconvene partners and decide on the path forward. For coordinated access, Ontario Health is leading implementation of a provincial system that will create a single point of access for referrals, and we look forward to understanding better the local impacts of that change. In the meantime, the public can continue to contact Access Line Niagara. We are also monitoring emerging community issues, including the withdrawal of funding for the consumption and treatment service in St. Catharines, which you'll hear from later. Positive Living Niagara is leading community planning in response to this change with participation from some of our working group members. We want to acknowledge the service the care this service has provided for people who use substances since 2018, and Positive Living's broader contributions across all its services.
We know that the Public Health and Social Services Committee has been concerned about mental health and addictions for a long time, and we appreciate that. So let's share the good news first. There have been new funding investments, such as Heart Hub and some system improvements provincially. And we want to thank the Ministry of Health and Ontario Health for those investments. So the first action is to invest in making a difference upstream rather than waiting for people to show up in the healthcare system. The second and third are not just about getting more money for providers to maintain their services. It's about modernizing the funding model so that funding goes to what is needed and where it's needed. That's the core services work I spoke about before. And if new funding becomes available, the Mental Health and Addiction Working Group is committed to working collaboratively so that we can plan in a coordinated way. Thank you.
Thank you, Laura and Lisa, for your presentation. So I'll call on Allison Chamber, from the Heart Hub Manager.
Good afternoon, everyone. My name is Allison Chambers, and I'm the Program Manager for Heart Hub Niagara with Gateway Residential and Community Support Services of Niagara. I am happy to provide you an overview and update on Heart Hub Niagara today. In 2024, we responded to a Ministry of Health call for proposals for the newly announced Heart Hub funding. For the proposal, we were asked to design a hub that incorporated a range of critical services based on identified community need, including mental health and addictions treatment, primary care, supportive housing, and access to social and employment services. To submit a proposal, we required endorsement from Niagara Region Homelessness Services to ensure the Heart Hub aligned with the region's current housing and homelessness strategy. Heart Hubs are considered demonstration projects with funding for Heart Hub Niagara confirmed through March 31st, 2028. In order to submit the proposal, we were required to identify a lead agency for the project who already receives funding from Ontario Health. It was determined that Gateway would serve as the lead agency given our experience in homelessness, mental health, and supportive housing. We are also the lead agency for Niagara Assertive Street Outreach, or NASO, and Housing First, so have significant experience in this field, and many of the clients we are looking to support are already connected through NASO. As the lead agency for Heart Hub, Gateway holds the contract with Ontario Health and is responsible for all reporting activities to them as our funder. We also have signed agreements with each of our funded partners and provide them funding for their services. Our services are grounded in Housing First principles, trauma-informed care, and a commitment to meeting people where they're at. Housing First has been shown to be an effective approach to addressing both homelessness and substance use. Recent research has found it to be more effective than treatment first models, with evidence also suggesting it can reduce the risk of fatal overdose and lower healthcare costs. As health and social service providers, we recognize that many of the individuals we support have experienced long-standing and complex trauma. We are committed to ensuring that services are delivered through a trauma-informed lens. Finally, meeting people where they are at is a core element of our service model. As a region-wide provider, we deliver service across Niagara. While our headquarters are located in St. Catharines, our staff meet individuals wherever they are in the community, including in shelters, encampments, and on the streets. We also take into consideration client preferences when discussing potential housing opportunities, recognizing that choice is important. The Heart Hub is a collaborative service model bringing together different providers and leveraging their areas of expertise to provide wraparound and specialized supports. This includes Gateway as the lead, with Niagara Region Mental Health, Reach Niagara, Quest Community Health Center, Data-Wada-Desney Aboriginal Health Center, Community Addiction Services of Niagara, and Oak Center Alternative Community Supports. I will speak more to each individual organization's role in the upcoming slides. We developed the eligibility criteria based on both demonstrated community need and provincial requirements. The Heart Hub is intended to support adults experiencing chronic homelessness with substance use challenges whose unique needs are often not fully met through existing services. This includes individuals with a range of complex needs, such as those living with concurrent disorders, so both mental health illness and addictions, and other significant health and social challenges. We are working closely with Niagara Region Homelessness and their coordinated access process to identify and connect with individuals experiencing chronic homelessness who may benefit from Heart Hub supports. If there are individuals in the community who require a connection to homelessness services, the best point of contact is by calling 211. By calling this service, this can enable a NASO referral who will connect with the individual and ensure they are part of the coordinated access system. The benefit of this is that it opens up opportunities for services beyond Heart Hub, as we are one of many services within the homelessness system in Niagara. I'd like to now provide an overview of the programs within the Heart Hub. We have 2 treatment teams within Heart. The Housing First Act team includes staff from Niagara Region Mental Health, with housing supports provided by Gateway, as well as referral opportunities to Data-Wada-Desne Aboriginal Health Centre. You will hear more about this team in the following presentation. The Integrated Care team includes staff from Reach Niagara, Quest Community Health Centre, Data-Wada-Desne Aboriginal Health Centre, and Gateway, with each organization contributing specialized supports based on its area of expertise. Clients also have access to an on-site primary care clinic staffed by nurse practitioners from Quest and a registered nurse from Reach. In addition, clients can access alternative community supports through the Oak Centre. This program offers a space where individuals can work toward their education, employment, social, and financial goals. The Oak Centre is located nearby at 264 Welland Avenue and operates using a membership-based model. Finally, as a housing-focused hub, supportive housing is a key and integral component of the Heart Hub, which I will speak to on the following slide. Across the hub, we have hired a housing engagement specialist whose primary responsibility is to engage with landlords, identify available units, match clients to housing, and help prevent evictions. One supportive housing opportunity for clients is market rent units in the community, with Heart Hub staff providing supports directly in the unit. We are also able to offer rent supplements to help improve affordability. We are also collaborating with CASN to provide abstinence-based housing supports and housing opportunities. Finally, and still in development, are some highly supportive housing units that will be staffed 24/7 with both housing and clinical supports available on site. This is an example of a client journey through the Heart Hub. The process begins with the Gateway outreach worker who receives an up-to-date by name list from Homelessness Services that has priority criteria including chronic homelessness, unsheltered homelessness, individuals who are shelter restricted, and individuals identifying as Indigenous. The outreach worker meets individuals wherever they are in the community, whether that is in an encampment, a shelter, or another location. They introduce the Heart Hub services, obtain consent to share information with Heart Hub partners, and complete a standardized assessment to support appropriate service matching. The individual is then brought forward to the collaborative intake table with representation from each partner. At that table, the group determines which treatment team is best suited to meet the individual's needs. From there, the assigned team begins building a relationship with the client and supporting them in working towards their treatment, housing, and broader wellness goals. I'm happy to share with you that as of today, we have onboarded 66 clients. 10 have been housed, with 5 actually moving in this week, for a total of 15 individuals will be housed through Heart. As the Housing First team is presenting next, I wanted to close by highlighting a couple of client success stories from the Integrated Care team. This individual was identified through the by name list and had been experiencing chronic homelessness since the beginning of the pandemic. He was living in an encampment when our outreach worker first connected with him and introduced him to Heart Supports. At that time, he was using fentanyl daily and had identified goals related to both housing and substance use support. With assistance from our housing worker, Gateway's housing worker, he was able to secure a market rent apartment supported by a Heart Hub rental subsidy to make the unit affordable. He was also connected to a registered nurse through Reach, who supported him in accessing addictions medicine, and he meets weekly with a clinical counselor to help advance his recovery goals. He is also connected to Oak Centre, which he attends regularly. daily. There, he is able to access a daily meal for $1, along with support related to his longer-term goal of returning to employment. He also receives peer support through Quest, which has helped strengthen his housing stability and overall well-being. The second client I'd like to highlight is a male in his 60s. He was in the hospital when our outreach worker first met with him. Prior to his hospital admission, he had been cycling between sleeping rough, shelter stays, couch surfing, and periods of incarceration. He identified a goal of abstinence-based housing supports on discharge, as well as ongoing support with addictions medicine. He has successfully transitioned to Heart Hub Casson Housing, where he continues to actively work on his recovery. Through interactions with this client, it was discovered he has Indigenous roots and has been connected to Day Desne's addiction counselor and Indigenous auntie for culturally relevant supports. These are just two examples of the incredible interagency collaboration and supports made possible through the Heart Hub, supporting individuals with their self-identified goals. Thank you for your time, and I look forward to answering your questions following the next presentation.
Thank you, Alison, for your presentation. I'll call on Dr. Rachel Lamont, psychiatrist, and Candice Chambers, supervisor for Housing First Assertive Treatment Service. Welcome.
Thank you, and good afternoon, everyone. My name is Candice Chambers, and I'm the supervisor for the Housing First Act team.
And good afternoon, everyone. I'm Rachel Lamont, the psychiatrist on the Housing First Act team.
So we're pleased to be here today to share information about the new Housing First Assertive Community Treatment team, or Housing First Act team. As Allison mentioned in their presentation, we're one of the participating partners of the Heart Hub and one of the services within the mental health programs at Niagara Region. The assertive community treatment model of care is well supported by evidence and is internationally accepted as an effective model of mental health treatment in the community. The Housing First Act team incorporates Housing First principles into the ACT model of care. Our team serves the people who need the most intensive supports available to obtain and keep their housing. The team will roster up to 80 clients, and there's no limit to the duration of service. Many ACT clients stay with us for years due to the chronicity of their illness and high level of need. In time, some will transition to less intensive services, and some will leave service altogether for various reasons. Our team is multidisciplinary, and we work together to address the different needs and priorities of our clients. Our clients are supported by our supervisor, our psychiatrist, Dr. Lamont, a program assistant, 4 mental health nurses, a social worker, an occupational therapist, a peer specialist, an addiction caseworker, a mental health caseworker, a behavior analyst, and unique to the Housing First Act team is the addition of our housing retention worker from Gateway that is embedded directly within the team. Our housing retention worker assists clients in securing and maintaining housing. Our nurses manage medication and monitor physical health needs. Our mental health caseworker helps clients secure needed documentation and access resources to meet their basic needs. Our occupational therapist supports clients in developing daily living skills and personal care. Our social worker provides individual, group, and family therapy, including cognitive behavior therapy for psychosis and trauma coping strategies. Our addiction caseworker offers counseling and support for substance use issues. Our peer specialist provides lived experience support. The behavior analyst will create management plans to help support with behavior, and our psychiatrist prescribes medication to treat both mental health and addiction challenges. Our Housing First Act team offers comprehensive support to clients 7 days a week and outside of regular business hours. The team meets daily to discuss client treatment plans, daily visits, and safety planning as needed. And services are provided directly in the community, whether that's within clients' homes, including encampments, shelters, or in public spaces.
I'm going to speak to you now a bit about what we mean by assertive in Housing First Assertive Community Treatment. That means that our team works persistently to engage clients wherever they are repeatedly over time. This can sometimes take up to 6 months to engage a client, though our team has not been in place for 6 months and we've been very effective at engaging clients thus far. An example of what this looks like on the ground, a young woman that our team has been supporting was previously supported by another ACT team. Had been experiencing chronic homelessness, had very severe chronic symptoms of psychosis, as well as heavy use of crystal methamphetamine and fentanyl. Our team started to build a relationship with her, and we were notified by the shelter she was in that police had picked her up and brought her to cells. I was able to go see her in cells with a nurse and talk to her about medication changes, both for her substance use and for her mental illness. And our team was then able to meet her in bail court the next day and deliver those treatments, which included injectable medications. And there's just no other service that's able to provide that level of support in the community than an assertive community treatment team. We absolutely meet people where they're at, whenever and wherever they are. So in terms of who we are seeing so far, we see individuals with very complex mental health and substance use needs. Most of the individuals we serve have psychosis and a diagnosis of schizophrenia, though not all. And most are heavy users of substances, including crystal meth and fentanyl being the most common substances used amongst our folks. In terms of the ACT standards are to onboard 4 new clients monthly. Our team has been exceeding that. So of the 66 HEART clients that Allison spoke of, 28 are ACT clients to whom we provide up to twice daily visits, 7 days per week, which includes medication administration and assessment of mental health, substance use, and physical health needs. Our group includes 10 females and 18 males, reflecting a mix of people who face complex challenges. Ages range from 23 to 58. The Indigenous clients supported by our team receive culturally appropriate services within the HEART Hub. In terms of a bit more detail about who we're serving, so 6 of our clients have obtained housing since being onboarded to the team, and the woman I just previously spoke of is actually moving into a group home unit this Friday. She's currently in a tent, unsheltered and service restricted, but has housing lined up, which is quite remarkable. We have 8 clients remaining unsheltered at this time, typically living outdoors or in encampments, with our team actively working to provide treatment and housing. We have 7 clients currently in shelters and 7 clients that are either in hospital or in custody. And just to highlight, the folks that we're working with our team are those that are highest acuity in the community. I'm going to give you a bit more detailed client story to highlight what that looks like. So the next is a bit of a more detailed story. So this is a woman who has a long history of severe and persistent mental illness, schizophrenia, and a severe stimulant use disorder, use of crystal methamphetamine. And she's been homeless since 2019 with short temporary stays in motels that really didn't last, and there was no long-term housing stability for her, and she had no connection to primary care or other community services. She had frequent police involvement, she had shelter restrictions in place, lots of violent behavior in the community, and was banned from a number of community spaces. And when we met her, she was living in an encampment. So our team started using assertive outreach to try and build trust. We would bring her things like food from the food bank or the soup kitchen, bringing water, naloxone kits. She was also living with her partner who had his own complex needs. And so we helped encourage him to access services and helped make some of those direct connections to services for him, as she was certainly not going to accept support from us unless her partner was also receiving what he needed. I met with this person directly in the encampment as well on many occasions to ensure she could access the care that she needed both for her mental health and her substance use. And so since our team has been involved, she has made remarkable gains. It's a delay, there we go. So she has had a remarkable reduction in her psychotic symptoms. She receives a long-acting injectable antipsychotic medication from our team. She receives prescribed medication for her substance use. She works with a clinician on our team with cognitive behavioral therapy, as well as does addiction counseling with the addiction worker on our team. She is housed and has been stably so now. She still requires daily support from our team, and we do that with daily medication administration, liaising with the landlord when needed to help resolve issues and help her maintain that stability in her housing. She is also connected to health and primary care and has had a number of her physical health concerns addressed. She's had no police involvement and dramatic reduction. I don't know that she's had any ER visits at all in the last little while. And we continue to support her on an ongoing basis.
Okay, as you can see from the client story that Dr. Lamont shared, we expect to see improvements in several areas of our clients' lives. Our outcome measures include a reduction in the use of emergency services, including hospitalizations and emergency department visits, connection to ongoing mental health and primary care services in the community, an increase in housing stability, a shift from unmet to met needs, adhering to the Health Quality Ontario standards by providing appropriate medication when and where needed, initiating long-acting antipsychotic injections, and offering treatment such as CBT for psychosis to decrease symptoms of psychosis, as well as offering addiction treatment. As I had mentioned earlier, the ACT model of care is evidence-based, and one of the ways that ACT teams measure their effectiveness is by tracking hospitalizations for clients. So the data that you see here is from our 2 pre-existing traditional ACT teams that are already in place in Niagara. You can see a dramatic reduction in the number of days that our clients spend in hospital after they begin receiving ACT services. And here again, we see another dramatic decrease, this time in the overall number of hospital admissions for ACT clients. As our team is new, we don't yet have hospital data available at this time. However, as we onboard more clients, we anticipate being able to share our data and expect to see a similar reduction in hospitalizations. So in the almost 6 months that our team has been running, we've reached several important milestones. The new team has been recruited and oriented. We onboarded our first clients in December of 2025, co-located at the Heart Hub site in January of 2026, and we've been fully operational since that time. The shared intake process for clients is established and operating to ensure that individuals are matched with the right care team. Collaborative implementation planning is complete, and the strong relationships among Heart Hub partners continues to support the ongoing rollout of service. Thank you.
All right, thank you for your presentation. I'll now go to the committee members, see if there's any questions for the presenters. Okay, I'll go on. Councillor Olson, if the rest of the presenters can come up as well, because there might be questions for the rest of you as well. Councillor Olson, you have the floor.
Thank you, Chair, and thank you to our presenters. They were great presentations, and you're doing some really hard work there, and I really appreciate, and we all appreciate what you're doing for us. I had a question about clarity of path to access. I saw different terms. I saw coordinated access, and I saw calls to 211. Is there a way that is there one way that a person can reach care by picking up the telephone or logging onto their computer?
So we are utilizing the coordinated access system that's already established through homelessness services. And the reason we're using it is so that we can truly target folks that have the highest need in our community. There are about 700 individuals in Niagara that are experiencing chronic homelessness. And so we want to ensure that the folks that we're supporting are the ones that would meet those eligibility criteria for HEART. So by utilizing 211, by ensuring they're part of the coordinated access system, if they require Heart Hub services, that would put them on the list for our care.
Okay. Yeah. Thank you for that, Chair. And through you, Chair, again, so are these referred services? Do you have to be referred by someone or a professional or someone to get to the services?
Through the chair, no. So we get an updated list from Homelessness Services weekly, which has those priority those priority clients identify. And with that list, we've also prioritized specific individuals. So individuals that are in encampment are closer to the top of the list. Individuals that are shelter restricted would be closer to the top of the list. Because we have access to Indigenous supports through our model, we're also prioritizing Indigenous clients. In order to be eligible for HEART, they need to be on that list. There needs to be chronic homelessness and a substance use disorder in adults as well.
Well, thank you for that, and thank you, Chair. Through you, I saw the notation from the last presenters on they were talking about tenancy support. What would that entail? Would that?
Thank you. Through you, Chair. The housing worker and actually all staff on the team do see clients in their units. A lot of times they're sort of basic supports around how to maintain a unit to keep it clean, how to follow rules that are imparted by the landlord, how to be respectful of other tenants in the building, in the space. And since our staff see our clients so frequently, we can sort of get ahead of and stay on top of any issues that come up. We also liaise with the landlords themselves. So if the landlord is identifying an issue, our staff will be a part of addressing that and making sure it doesn't continue.
I can add to that as well. So we have hired a position called a housing engagement specialist, and that role truly is to work with landlords, to find units, to build relationships with landlords. If there is a landlord concern, that would be their primary point of contact, and then that individual liaises with a team on how we can manage concerns with landlords. So it's really building those landlord relations, and we're finding that's actually quite crucial to finding units and getting more units available to us.
Okay, thank you. Through your chair, is there an occupational element to this too as well, for jobs or, I guess that'd be, my words would be occupational support. Is that available too?
Yeah, through the chair. So our partner, Oak Center, they provide employment supports. So if an individual has identified employment as a goal, they work closely with that individual on those employment supports, and they have a couple of employment-related programs within their agency. There's one called Transition to Employment and one called Supported Employment. So that is available for folks if that is an identified goal. The Housing First Act team has an occupational therapist as well who supports with employment goals.
Thank you. And finally, Chair, the results you're getting in hospitalization, that has to be regarded as remarkable. I mean, 86% reduction in hospitalizations is and how does that get evaluated by the province when they look at these programs? And these are test programs, and that's got to be a positive. I mean, what is the dollar savings has got to be huge from that.
Absolutely. That will be one of the indicators we'll be monitoring over the time to show the efficacy of the program. Absolutely.
Thank you, Chair. I find it remarkable what's been done here. Thank you.
That's great. Thank you, Councillor Olson. I have Councillor Cisco next.
Thank you, Chair. A couple questions. The first one, just going back to something Councillor Olson asked, with respect to intake. So are you saying that all of the clients are coming from a list provided by Homelessness Services? I just want to make sure I understood that. So is there any ability for community agencies to be making referrals to this, or is it these folks have to be captured within the system?
Yeah, through the chair. So we would encourage community agencies to ensure they're connecting with NASO so that those names could then, so that those individuals would be then on that list and prioritized for service. That's the pathway.
Okay, so for outside community agencies, they have to be connecting through NASO. That's
through NASO, or if they're in shelter, they would be on that list as well because they're part of the homelessness.
They would be captured in that number. That's
absolutely
okay.
Yeah.
You sort of laid out the client journey in through that intake pathway. I'll admit it looked convoluted, but it's on the screen and I understand that there's a process for it. I'm wondering, how are we ensuring that this stays low barrier and that, clients don't get fed up in the midst of the process? What's the timeline associated with this?
Through the chair, thank you for the question. So I would say that outreach worker can be pretty effective. They can go out, they can meet with the individual, complete the intake assessment. And again, it's up to the client too, because the intake assessment might take a couple times, like over a couple of visits, and then the individual would then be presented to the table. So it can be between a week to a couple weeks from initial contact with client to onboarding to the treatment teams.
Okay, so anywhere from 7 days to 28.
Yeah, and in that time too, that the outreach worker would continue to connect with the individual, so they wouldn't be kind of dropped without service. That would be the primary point of contact with the Heart Hub, would be the outreach worker, until they've been successfully transitioned to a treatment team.
So that contact then, during that intake period, how regular is that contact? Is it daily contact? Is it weekly?
It would be based on the client identified need, yeah.
Okay, shifting gears slightly. You had a client journey and you talked about, some of the medications. What sort of addiction, medicine, recovery services, what exactly is what's the breadth that's being offered?
Through the chair, thank you for the question. So we are offering both medication therapies and addiction counseling, one-on-one therapies, as well as connection to community agencies if a person is appropriate for that. What that looks like on the ground is prescription of opioid agonist therapy, so Suboxone or Sublocade, the long-acting injectable form of Suboxone, or methadone, or sustained-release oral morphine. In addition to that, we do have some small evidence for stimulant use disorder medications as well, which can be prescribed, as well as anti-craving medications for alcohol use disorder. So the full breadth of pharmacotherapy for substance use disorders is offered in addition to counseling and supports. As well, we connect people with harm reduction services in the community, such as positive living, if that's what they need.
So with respect to Suboxone, Sublocade, I've read a lot over the last couple of years with respect to those two medications, and I'll admit I sometimes mix up which is which, but sometimes they're portrayed as like the answer, and then sometimes they're portrayed as the devil. What sort of results are you seeing with them?
Through the chair, thank you for the question. So in this population, our initial result really that we're looking for is to help people, help to prevent overdose, because that is a very common occurrence in individuals using fentanyl, and also to reduce substance use over time. Some people have the goal of abstinence and others do not. We have seen many individuals reduce their use dramatically with prescribed opioid agonist therapy.
Okay.
And it is absolutely the evidence-based treatment for those conditions.
Okay. We know the CTS is closing. Is the Heart Hub coordinating with the CTS, given the changes that are coming and the concerns that have been raised within the community? Is there a coordination effort going on there?
Through the chair, yes, and you'll be hearing from Talia, I know, later. So in preparation for the upcoming CTS closure, we have been working with the local CTS provider to identify and prioritize individuals who meet Heart Hub eligibility and who are interested in receiving services.
Okay, so with respect to that eligibility, given that we know that this service is likely disappearing in about a month, are we looking at any changes we might make to the eligibility criteria?
Through the chair, as of right now, we are sticking with the eligibility criteria, given that our focus is chronic homelessness. And so we continue to support individuals who are experiencing chronic homelessness with substance use disorder.
Okay, so I guess I'm trying to understand, there are folks that are currently being served by the CTS that aren't going to meet that criteria. What are the alternative pathways for them? Where are they headed if the eligibility criteria is not being expanded?
Through the chair. And I'm sure Talia can speak more to this about the folks that aren't being connected to Heart Hub. I know they're looking at alternate providers and community that can support them.
Okay. My last question, and this may seem like a strange one, but it's been a question I've asked in other contexts, and it seems to drill down on some things. You identified some success stories, and that's wonderful. I'm wondering what lessons have been learned from failure since you've started accepting clients. Are there additional service providers that need to be better integrated into the Heart Hub? Things like that.
Through the chair, it's a good question. Obviously, it's not, the road's not going to be smooth. It's definitely a journey. As of right now, I think it's something, we're so early stages into the process, and we've really been working on establishing our procedures and how we do the work. I think it's something we're going to just have to monitor ongoing. I'm not certain of anything glaring at this time, but absolutely, it's something, because it's a demonstration project, it's something we're definitely going to keep our eyes on that.
Okay, I appreciate all of the presentations. I know that, at least I'm almost positive you'll be coming back to give us more presentations in the future. I think the request I would make from those future presentations, if we could see failure, not that I want to dwell on it, but I think it's important for us to recognize if there were things that were missed in the original creation of this program. And maybe if we're identifying avenues that are going to require additional funding from this body that we need to be made aware of sooner rather than later. If I could ask if that could be a part of a future presentation. I don't need a laundry list, but whatever those glaring things are, because eventually they will come out. I think that would be helpful for everybody around this table.
Through the chair, as I've been listening to that request, I would say one of the, what has been made clear to us is that the amount of caseload spaces that we have a number of caseload spaces, doesn't match the amount of supportive housing opportunities that we have. And so we continue to seek partnerships and other opportunities to increase the amount of housing opportunities for our clients. I would say that would be a goal of the program, is to continue to increase the amount of housing for folks.
Okay, and I really appreciate that, because I think this regional council has made an effort over the last couple of years, but the last 6 months specifically with respect to supportive housing. That's exactly what I would love to have come back here, because I think demonstrating that need to public health and then to regional council is going to make the path much clearer in future years about how we allocate resources to build out that supportive housing master plan and the highly supportive housing that we've identified within it. So I appreciate that. Thank you very much, Chair.
Thank you, Councillor Cisco. Have Councillor Encina next.
Thank you, Chair, and thank you for the presentations. Just a few questions, I guess, some from clarification also. You had the number of qualifications that people, requirements, let's call it that. If someone doesn't meet that qualification as an addict, they're sent elsewhere. Is that my understanding?
So through the chair, yes, if somebody comes up on our list and doesn't meet the eligibility criteria, we would look to connect them with alternate supports.
Okay, so let's say someone doesn't have is chronic homeless and everything else. He's got to go somewhere else. Can't go to the Heart Hub. He has to go somewhere else. That's right, because if he didn't have an addiction.
Through the chair, yes, we would look to connect him to alternate resources.
Okay. How many people do you have, you explained about the client's journey. How many people do you actually have that go out and talk to these people?
Through the chair, are you looking at total number of FTEs currently hired through Heart Hub, or are you wanting to know about our outreach efforts?
No, I'm talking about outreach.
Outreach. Yeah. So
Yeah, you talked about this. You talked about the journey. So they are identified. Someone went out to see them. But what are your numbers like?
yes. So through the chair, currently we have one outreach worker that's been hired that's doing the connecting to the hub. And then once they're on the treatment team, there's a number of other individuals that are then going out to work with the client. I believe we have up to about 30 FTEs hired for the hub as a whole.
Okay, I'm going to ask, how come there's only one?
Through the chair. The one outreach worker is actually quite successful. So at the time that we've been open, we've onboarded over 66 clients and continue to onboard clients very frequently. So the model does appear to be working quite well.
Okay, well, through you, Chair, that's I understand that, but to have just one person do it, I'm not sure. On several occasions, those have I know people who have called 211 and get hopefully get a response, and two, get a response that no one's in the area. How is that going to be accounted for with the Heart Hub? How does that work? You're saying everything has to go through NASO. Your lists have to be through NASO. But if NASO doesn't come out or NASO can't be reached, how does someone move forward?
Through the chair, I'm going to ask Director Cousins to speak to NASA-related questions, as that's not my area of expertise. If I could get Director Cousins to comment.
Thank you for the question through the chair. So what I will offer is, we know NASO is not 24/7, but NASO does run 5 days a week, does have extended hours. So there are opportunities for individuals. There is an after hours line, you can leave messages, and somebody will come out and visit the individual. But I think the other piece to the counselor's question, let's go through an example of somebody who is new to the system, but might actually have been homeless for an extended period of time. So once NASO connects with them, as part of the work that they do in alignment with the Heart Hub, and we do work very closely with everybody, we would take their housing history. So even though it is our first interaction with you on a Friday afternoon, we may very quickly realize, but you meet the criteria for chronically homeless, and therefore would automatically then move up to that portion of the by name list that we would refer to Heart Hub on the next week to start that conversation. And then I think there was also a question earlier about who comes out to talk to those individuals. While outreach may be first, once they're transferred over into the realm of Heart Hub, there are 30 other workers who will then come out and meet with them still out in community or in their encampment. And I think in one of the examples that Dr. Lamont used, she even referred how she herself is out in the field in those encampments providing those direct services.
Thank you, Director. If I can continue through you, Chair. Okay, I'm sorry. I'm stuck on having one person going out to see all these different people, because I'm thinking, okay, who's being missed? How does an outside agency not listed on Heart Hub, how does an agency become involved, or is this kind of like a selected thing?
Through the chair, are you asking a question about referrals to Heart, or are you asking about partnership with Heart?
I'm asking about partnerships and partnerships with Gateway and things like that, yes.
Yeah, through the chair. So the list of partners that were in that presentation are our funded partners. That doesn't mean that we don't have partnerships with other agencies and community, whether that be, encouraging them to work with NASO, or if there are services that our clients would benefit from, we would look to develop that partnership. So those are the funded partners, but absolutely we're open to conversations with other community members if it does make sense.
Well, through you, Chair, do you have a list of agencies who are unfunded but provide the same work?
Through the chair, similar to Heart Hub services, the same work as Heart Hub?
Similar, not as involved.
So I would say the most similar work to Heart Hub would be NASO, as we mentioned, and we work very, very closely with NASO. And I think Director Cousins did highlight that NASO has a lot more workers than our one outreach worker. Our outreach worker is really to connect them to Heart. However, NASO is out in community connecting with a number of individuals daily. And then we do work closely with other Gateway programming. There's a Housing First program that also does similar work, so we work closely with them if there are clients that require Heart Hub services and vice versa.
Okay. Through you, Chair, if I may, just one last. The majority of clients are centered around which communities?
Through the chair. So I did think that might be a question. So I did kind of pull some stats by municipality. So I mentioned we have 66 clients onboarded currently. 42 of those are in St. Catharines, 13 in Niagara Falls, 9 in Welland, 1 in Port Colborne, and 1 in Thorold currently.
Thank you, Chair.
Thank you, Councillor Encina. I have Councillor Bateman next.
Thank you. Good for you for anticipating questions. That's impressive. First, Chair, I'd just like to thank everybody. This was a lot of information and extraordinary, really, what this is what we've been able to do. I'm going to put the royal we in that. And I just want to thank Mayor Cisco for his questions. I thought they were bang on, very well informed as well. We get a lot of, through you, Chair, we get a lot of people say that people are put on buses from other regions and sent here. Can you speak to that? What is the, do you find that to be true? You're looking surprised. I can tell you, I honestly get that probably once a week.
Through the chair, are you speaking for mental health and addiction services or for Heart Hub services? Are you asking?
For housing and homelessness services, I think I would encapsulate it all, really.
Through the chair, I think I might redirect that question to Director Cousins as well.
Thank you for the question. And through the chair, that is a conversation that regularly comes up in community. I do agree. It is something that we address every other year as part of our survey questions during our point in time count. What I can suggest to you is there's always a percentage of individuals who don't define some element of Niagara region as their home community. That percentage is pretty consistent. And when I go and talk to my peers in other communities, Windsor, Waterloo, they have the same type of percentage. So I don't think there's an influx. There is a constant state of individuals that would not define Niagara as their home.
Thank you.
Usually about 15%.
Thank you very much. You mentioned through you, Chair, you mentioned service restrictions. When we have service restrictions here, you're still able to provide support. Are there any restrictions that you have as part of your programming?
Through the chair, safety is always a priority for our staff, and we do have a risk assessment that we have staff utilizing to assess risk when they're working with clients. And so that would be really an ongoing assessment of risk with clients. At this time, we haven't had the need to restrict any individuals from services. I don't know if Dr. Lamont wants to speak. Yeah.
Through the chair, I will add, most of the folks that our team serves are considered high-risk individuals, high risk of aggression, and have many of those service restrictions. And so our staff are very skilled in working with folks. We have not turned anyone away as of yet to be supported by our team, even those individuals that other teams have declined to serve. So we are there trying to do the work. Ultimately, if there's a major safety concern that arises, that would need to be revisited, but we don't have any specific restrictions at this time.
Wonderful. Thank you, Chair. Thank you. And through you, Chair, I know that, I don't know, but there's a lot of conversation out there about trafficking, and it is a big part of the unhoused population. And I'm wondering if you can speak to what you've come across and maybe how you've handled those situations.
I could, through the chair, I can speak to the on-the-ground part of that. We have at least one individual, a young woman. You're speaking of human trafficking?
Yes.
One individual who we've had concern for that. Our team sees her every single day and provides ongoing support and tries to assess for any vulnerabilities to make sure that she has safe space to go to and safe people to contact. She hasn't directly endorsed being trafficked, but we've had a lot of concerns about that because of activity that's happened around her. But we haven't had anyone specifically that's been trying to exit trafficking.
Okay, thank you very much. And you've mentioned Datawad Nesne. I don't know, I've not heard of that program or that group. Could you speak just a little bit more about that? And that's my last question, Chair. Thank you very much.
Through the chair, we're really thrilled to have a partnership with Datawad Desne Aboriginal Health Center. They're located in the same building as us, which has been really quite lovely. And so having staff from that center embedded within our treatment teams has been extraordinarily valuable. So if a client is Indigenous and is seeking those culturally relevant supports, they're connected directly to Datawad Desne. They can also access primary care through Datawad Desne if that is their goal. So it's been a really great partnership, and the ability to be able to offer those services to clients has been extraordinarily valuable.
Thank you, Councillor Bateman. I now have Councillor Easton next.
Thank you very much, Mr. Chairman. Thank you from the presenters. It's a very important and certainly long sought after program. Mr. Chairman, my question is about compliance to begin with. And I'd like to know how are you measuring compliance? It sounds, as you're describing it, that there's quite a bit of tolerance with this, with the program. But how are you measuring compliance, and how is it, and how are those numbers looking just overall with this early experience?
Through the chair, thank you, Councillor Easton, for the question. I guess there are a few ways that one could consider compliance, and I just wanted to clarify. Did you mean compliance with medication? Did you mean compliance with working with the team? Both?
I mean, whatever criteria you have for establishing compliance, I'm interested in because, and I'm asking the questions because it gives me a sense of the complexity of what you're dealing with and whether or not in this environment where people are in shelter settings and unsheltered, very unstructured environments, whether it's actually possible for people to be compliant according to how you define it.
So through the chair, I would say that we don't necessarily measure compliance. We make treatment recommendations, and based on an individual's willingness to engage or not engage with those treatments, we would meet them where they're at. There are exceptions to that, of course. We have many individuals who are on community treatment orders and receive long-acting injectable antipsychotic medications through those community treatment orders. We can initiate those treatment orders in the community for a small subset of clients who meet criteria under the Mental Health Act for that. And for those individuals, really the only compliance that can be measured is whether or not they're receiving their injectable medication. And if they're not, they're to be brought to hospital by law enforcement to receive their injection. I would say the vast majority of people for whom we recommended medication treatments, they have been willing to accept at least one of our recommendations, often more. And with time and trust, people really do begin to accept the treatment being offered. That's been my experience thus far.
Okay, that's very interesting. So what are you using then for measurements of success? If it's the individual care plan that you're examining?
Yeah, through the chair, we're definitely looking at accessing treatment. We're looking at housing. We're looking at housing stability, just a number, connection to services. So really looking at the individual treatment plans of each client and how we can support that client with those indicated goals.
Okay, so that's good and that's clear. However, what happens if the level of ability in those criterias, if they're not able to respond effectively, maybe they're not funded well enough, maybe the expertise isn't there, what happens to your program? Where do you turn to try and get a better shake for your clients?
Through the chair, I would say the folks that are working with the Housing First Act team, we are by and large the end of the line that provides the most intensive supports. And so if we are not able to support an individual, we look at advocating for hospitalization to offer a period of stabilization. And we do have strong relationships with the psychiatric emergency department and with the inpatient mental health physicians, that we are able to work closely with them to advocate for our clients to be admitted and treated.
Okay. All right. I think one of my original perceptions of this program was that there was going to be, because the programs are well evolved in many, many cases, that you would be getting support, I would say, over 90% of the time for your clients, so that you wouldn't have disappointments, so that they wouldn't have disappointments. Do you think that's happening?
Through the chair, yes, we've seen clients engage and do well a majority of the time. One of the questions that was asked was in our efforts to engage with folks, how many have declined services? We've only had 2 folks decline. So when the service is offered to them, majority of individuals are willing to work with us and accept services.
Okay, so I just have one more question. This has to do with referrals from other parts of the system. And it's obvious that this is a pretty specialized team that have been put together. And, maybe other parts of the system are a bit tired now. It's been a pretty long haul for the last few years and lots of change as well. So do you find that your referrals are a little higher than you anticipated that they would be?
Through the chair, thanks for the question, Councillor Easton. So that is why we are using the coordinated access system to ensure that we're targeting the folks that have the highest needs in our community, as these are the specialized treatment teams that are really truly working to support the individuals where other services are not necessarily have been able to meet those needs.
Okay, but what happens if they're not coming to you? And this is where some of the highest level of expertise is. What happens to those people in terms of the resources that are available to them from other sources? Will their conditions improve? Will they stay the same?
Through the chair, I just again was wondering if I could clarify the question. Is this for individuals who are not appropriate for heart services but that require support? Is that?
Well, I think that's a smart response, because I was wondering if maybe you were being seen as such great experts, which obviously you are, that there would be a greater number of referrals from areas where they were really struggling with their own resources and what you were doing about that. I was trying not to be so blunt about it, but I'm trying to help you.
Through the chair, I mean, I can speak to many of the intakes that I have done. A lot of individuals are in an Niagara Detention Center. I would say we're seeing a lot of connection point with folks that are there. Folks identified through the situation table, people in the forensic system that are only going to be there for a brief time and release back to community. Those are a large proportion of the folks that we are meeting and serving.
Okay. There's a lot of understanding to happen on our part as well, but I certainly appreciate your efforts. And it's a good report. There's enough here to get us thinking. Thank you so much. Thank you, Mr. Chairman.
Thank you, Councillor Easton. I have no other speakers on the list. I just want to thank the presenters for being here and answering these tough questions, good questions at that. And they did an excellent job responding. It is very valuable information. I know it's early on still, but I think once we get going, another presentation, another 6 months or so, I think we'll have more concrete numbers and a better understanding on where we're at. But thank you for being here and your presentation. Next, we're at delegations. We do have one delegation here this afternoon. A mental health and addictions working group update. So there's one, I'll call on Talia Storm. I said that right? Director of Street Work Services, Positive Living, Niagara, for the delegation. And remind Ms. Storm that we do have 10-minute time limit.
Yeah, 10 minutes.
Thank you.
Okay, hello everyone. My name is Talia Storm. I'm Director of Street Work Services at Positive Living Niagara. So as alluded to by the other presenters, we are working hand in hand around navigating Niagara's toxic drug supply. So today I'm going to touch on supervised consumption and drug checking services and how that relates to what we've heard today. Okay, so Ontario has faced a sustained toxic drug supply crisis for years. At one time, Niagara was often in the top 3 of all the lists we didn't want to be on in terms of overdose deaths, EMS calls, and emergency department visits. As overdose deaths continued to rise across Ontario, supervised consumption services were introduced back in 2018 as an immediate measure to preserve life and connect people to care. So our supervised consumption site, or Consumption and Treatment Services, which is the provincial name for things, opened in December 2018. Since then, we have been open 12 hours a day, every day of the year, minus the time it snowed 50 centimeters in a day. What I'd like folks to keep in mind today is to think of this as a bit of a case study for one neighborhood, because we know that sites serve a relatively small geographic area. CTSs are often misunderstood as single purpose, when in reality, they offer many relevant wraparound supports. For many people, CTS is the first and/or only consistent point of contact with the healthcare system, and it disproportionately serves people who already face barriers to care, including homelessness, systemic racism, untreated or undiagnosed mental health. The primary focus of the site is to offer supervised consumption and overdose response. In the last fiscal year, we've supported over 300 people, had over 7,500 visits, and 141 overdoses have been reversed in the space by paramedics who provide dignity, privacy, and safety, all while reducing pressure on EMS, hospital, and the general healthcare system. Since we opened, we've reversed over 1,500 overdoses, had 89,000 visits, and thousands of connections to other services. Access to drug checking services and market monitoring empower people to make informed decisions while helping us understand the unregulated supply of substances, which is the challenging part of the work that we're doing. CTS reduces public substance use, prevents infection through access to harm reduction supplies, and provides a sterile environment, provides education on safer use practices, and provides safe biohazard disposal to reduce syringes found in community. It's a necessary service to keep people alive and healthy until they are ready for treatment services, should that become one of their goals, which we do see quite often. We work very proactively with partners in the neighborhood and our residential neighbors and businesses, listening to concerns and working together on solutions. One of the goals of the program is building community capacity and reducing stigma. We can't do what we do without the support of our partners in the site. You've heard them listed many times today with other initiatives. That includes Niagara EMS, Community Addiction Services of Niagara, Des Joie de Desnay Aboriginal Health Center, Gateway's Nassau team. Hospice Niagara is currently in the site offering grief support. Niagara Region Public Health Outreach Nurses, Quest Community Health Center, Reach Niagara, and we are working with the Heart Hub to try and transition as many clients as possible to those services. From a system impact perspective, we need to look at the bigger picture. CMHA estimates that every overdose reversed in a consumption site saves the system approximately $1,600. That also doesn't include prevention of infection. One HIV infection costs the system $1.44 million. A 2020 study by the Canadian Institute for Health Information found that for every $1 invested in a consumption site, there was an estimated savings of $2.80 in healthcare and law enforcement costs due to reduced overdose deaths and fewer emergency room visits. However, we have some current risk for the site. So back on March 13th, the province announced that it would no longer be funding consumption sites across Ontario. Another nuance to this is that our federal exemption allowing people to have illicit substances on site expires at the end of September. However, we have seen in other communities what's happened where sites have closed. 9 sites were forced to close by March 31st, 2025 under Ontario's Community Care and Recovery Act, and emerging studies are demonstrating the negative impact site closures have in communities. CTS closures appear to move harm elsewhere, increase strain on the system, and lead to preventable deaths. When supervised settings disappear, overdoses occur in alleyways, washrooms, shelters, and private residences. This means overdoses are happening in uncontrolled settings and more high acuity presentations to emergency departments occur. In Hamilton, where the city's only CTS closed in April 2025, opioid-related EMS responses rose from 66 in April of 2025 to 199 in February of this year. That's the highest recorded monthly count since reporting began in Hamilton. One concern is a disruption to drug checking services, which prevents access to potentially life-saving information. And new preliminary data is showing a 38% increase in crime where sites have closed in the Ottawa area. In terms of risk mitigation for a potential closure, we are working alongside Public Health and the Niagara Substance Use Strategy, Community Services, MHOG, and many other community partners and neighbors on some of these risk mitigation pieces. We are working with partners to develop overdose policy and response effort as we're preparing for the impact of these overdoses to move elsewhere. Part of that includes staff capacity building at those sites as well. The Toronto Drop-In Network reports a 300% increase in overdoses happening on site where sites have closed in Toronto. There's a lot of work happening for St. Catharines around coordinated street outreach, ensuring we monitor where substance use relocates and to ensure people's safety. And data tracking and analysis is a significant part of this to continue to adapt to changing community needs. We want to ensure continued access to drug checking and drug market monitoring. Drug checking and market monitoring is crucial to prevent drug-related harm and inform evidence-based responses to the ongoing toxic supply crisis. We are no longer dealing with a very predictable opioid environment where naloxone works. People are using substances with unknown potency, unknown contents, and high contamination with fentanyl, benzodiazepines, and other substances. The unpredictability of it makes it hard to manage from a healthcare lens, and so this is very much about risk management. In terms of what drug checking currently looks like in Niagara, we have been offering this service out of the consumption site since winter 2024 through a partnership with Scatter and Western University. The Scatter device uses Raman spectrometry, analysis of light absorption and emission of substances, which essentially provides a snapshot of the substance someone is testing. Clients provide a very small sample of their substance, the size of a tip of a matchstick, and receive results in under 5 minutes with more detailed results in 10 minutes. The sample is not destroyed, but clients do have an opportunity to send the substance away for further testing if they choose to do so. Looking at data for the most recent fiscal year, 31% of the scans resulted in people choosing to reduce their use or dispose of their substance altogether, truly demonstrating that knowledge is power. This is a very strong percentage in terms of demonstrated change in behavior. On average, with the drug checking, we find 3 to 4 substances within each expected fentanyl sample. This can often up to double when samples are sent away for further analysis. But it's important to note that Scatter has limitations. There are type parameters on types of substances detected. There are challenges reading substances that are in low concentrations. The turnaround time can be significant to get results back for samples that are sent away to the lab. And it is now suggested to pair the Scatter device with drug testing strips, which many public health units are currently funding. And those strips help test for the presence of certain substances. Should the site close, efforts will be made to relocate the device. However, we are also seeking to expand drug checking services across Niagara. Drug checking allows for the collection of early data on the local drug supply to identify unexpected substances, potency changes, and emerging trends that can inform alerts and community responses as part of larger community drug surveillance measures. This allows frontline workers to disseminate information quickly to people who use substances. And in fact, as we sit here today, we are currently in an adverse reaction advisory for a recent surge in overdoses. And based on recent data, it's looking that alert is going to be extended. We also work with sites across Ontario who are doing similar work and working with the Ontario drug checking community to be able to identify provincial trends as it relates to substances. Despite strong local harm reduction infrastructure, access to drug checking remains limited to one neighborhood, leaving many residents, particularly those in rural communities and smaller municipalities, without timely access to life-saving information. Mobile drug checking and market monitoring services seek to mitigate the harms of the potential loss of the consumption site by offering a new model of mobile service that will also scale the benefits across the region. Mobile drug checking services are a proven evidence-based intervention that reduce overdose risk, improve service engagement, and strengthen real-time drug market surveillance, allowing us to be more proactive as a system. An application has been submitted to Health Canada for mobile drug checking and market monitoring services to expand throughout Niagara, which will give us far more information to work with. While the timeline is unclear, if this is approved, it will be embedded into existing outreach services at Positive Living Niagara. Defunding supervised consumption services should not mean losing access to drug checking, toxic supply monitoring, or evidence-based public health surveillance, as these services remain essential for community safety, overdose prevention, and an informed public health response. Thank you.
10 minutes right on. That's. I'll go to councilors to see if they have any questions for the presenter. Councilor Bateman?
Thank you, excuse me, thank you, Chair, and thank you, Talia. If you give me just a 10 seconds, Chair. This might be the last time I see you at this table with me in this position, so I just wanted to thank you for always being a resource to me. I really appreciate it. What is the biggest misconception about offering the services that Positive Living offers? What do you think is?
To clarify, in relation to harm reduction, the consumption site, or drug checking, or all of the above?
I would say all of the above, because I think looking at your presentation, those who know your services may still not know the amount of work you do as a group. And I'm curious to know, as somebody who's kind of defended it when I get those calls, I'd like to know what you think about that.
Sure, through you, Chair. Some of the things that we hear most often in relation to harm reduction and the work that we do are in relation to enabling substance use, when we know that substance use is happening in our community regardless. So our goal is to keep people as safe and healthy as possible. As touched on in many of the other presentations today, people have a right to choose service. And so some people aren't quite ready to access treatment services, or when they are, they may not be available. That's a fairly big misconception. The other is that the consumption site provides substances to people, which is not the case. People are bringing their pre-obtained substances on site for testing.
Thank you. Through you, Chair, what can the region do to support continuing these services, or what does it look like come September? And I don't want to say it seems coordinated, but the timing lines up, right, with the federal government and the provincial government.
Specific to the consumption site?
Yes.
Through you, Chair, there are limitations on how much municipalities and regions can support based on current provincial legislation. I think ensuring that we're following evidence-based services as much as possible and providing that support is important. And I think being able to speak publicly about the nuances of substance use is also important, and the benefit of harm reduction in our communities.
Thank you. And through you, Chair, would advocacy to keep the site open, would that be helpful? Is that something that you and your group would appreciate?
Through you, Chair, always appreciated. We have had an outpouring of support from our neighbors and community partners in relation to the announcement about funding. We've received more letters than I can count at this point supporting the work that we do. So again, always pushing that these services are evidence-based and can make a real impact in community. We are quite concerned about the impact to the broader healthcare system with this decision, particularly for our friends at Niagara EMS and the hospital system in terms of what this ripple impact could look like. Again, there are sites that have closed in other communities, and there's a lot of research going on about the impact in that way. So it affects more than just folks who rely on the service, but the broader neighborhood and community as well.
Thank you. One last question, Chair. Having the Heart Hub group here talk about their services, there's a misconception, I think, that their services replace yours. Can you speak to that?
Sure. Through you, Chair. On the day that the Community Care and Recovery Act was announced, when it changed the ability for sites to operate within 200 meters of childcare centers, that's when Heart Hubs were announced. The province at that time did indicate that they were a replacement for supervised consumption services. We see the full, the need for the full spectrum. We need the supervised consumption component, and we need services like the ones that Heart Hub offers.
No other questions. Thank you so much, Tally.
Thank you, Councillor Bateman. I have Councillor Cisco next.
Thank you, Chair. Through you to the presenter. Thank you, Ms. Storm, for the presentation. One of the complaints, the frustrations that I get in my office on a regular basis is that we have a supervised consumption site, but people are still seeing a lot of public substance use, and specifically, they're complaining about it, in the neighborhood where the consumption and treatment site is. I'm wondering if you could sort of comment on that.
Yes, through you, Chair. One of the barriers of the site has always been that we have not been permitted to provide inhalation services. So anyone who is smoking their substances cannot use their substances at the site, and that has been a significant barrier. Since about 2018 or 2019, we've seen a continued shift towards inhalation use and away from injection use, which is a win in many ways in terms of infection prevention, in terms of syringes found in community, but it has left a large portion of folks who use substances through inhalation without services, and that's where we still see that happening in community.
Okay, is inhalation, is it less dangerous than injection?
Through you, Chair, it depends on what metric you're looking at. It used to be a safer way when it comes to overdose. That is no longer the case, but it is a much safer way to use in terms of infection prevention. So looking at HIV and hepatitis C, for example,
Okay,
and wounds in general.
Why would the has the overdose rate increased with inhalation over the years? And if so, why?
Through you, Chair, I can't speak to that. The overdose rates are always kind of fluctuating, but where overdoses are more complicated are when they do happen in public settings and not a controlled setting like a consumption site.
Okay, thank you.
Thank you, Councillor Cisco. I do have Councillor Olson next.
Yes, thank you, Chair, and thank you for the presentation. And I'm becoming more familiar with your services all the time that you offer. So I was wondering about if you could expand a little bit on the mobile drug checking process. Is that a scheduled process or an on-call type of thing?
Sure. Through you, Chair, if we are approved for mobile drug checking services, it will be embedded into our current outreach services that operate Monday through Friday in the evening hours throughout the region. The mobile component of our service has always been very important to reach our rural neighbors and to ensure that there's access to support there. So the scatter device would be located in our outreach vehicles and people would be able to access. The way that service works is that people simply call or text and ask to see us on the evening and we make our way to them. So on-demand service.
Thank you, Chair.
Thank you, Councillor Olson. I see no other speakers on the list. Thank you for your presentation. Again, very informative. Thank you. Now we go to number 6. It's items for consideration. We have 6.1, PHD 5-2026, endorsement of Bill S-202, alcohol labeling position policy. I need a mover and seconder for that. Moved by Councillor Cisco, second by Councillor Woodavine. Any discussion? I'm seeing none, so I'll call the question. Please vote electronically. And that carries. Thank you. We go to number 7, consent items for consideration. Does any member wish to vote on any of the consent items separately? I'm seeing none. Oh, sorry. Who? Oh, Councillor Woodavine.
Yeah, Mr. Chair, I just would like to ask a question on item 7.2. So it's don't really need to pull it. I just would like to ask a question on that item. So can I do that now, or?
If there's anybody else that wants to move an item and vote on it separately, if not, then we'll move the consent items from 7.1 to 7.4. If we can vote that, I'll call the question and vote that electronically now, and then we'll go back to 7.2. Discussion now. All right, sorry, Councillor Woodin. Yeah, we'll discuss this one now, and then we'll vote on it.
Okay, thank you.
Sorry, before we do that, I do need a mover and seconder. Moved by Councillor Bateman, seconded by Councillor Whalen. Go ahead, Councillor.
Thank you, Mr. Chair, and I guess my question be directed to Sandy on this. So my concern now that we have basically the Heart Hub in progress here, and it's dealing with addictions and recovery and treatment. So my question is, we have treatment facilities in our region. So we still need that component for a person that's willing to go in and for I call it, I'll say a full rehabilitation, and so my question is, what is that ratio that we need those full recovery beds for as per our gross population?
Okay, well, thank you for that question.
Second question, so.
Okay. Dr. Guzmani, do you have someone?
Chair, I may ask if any of the staff who presented have a good answer for that.
Go ahead.
Through the chair, first, just to, if it's okay to clarify the question, if you're asking about the number of beds we require, is that what you're speaking about?
So, yeah, so what I understand is the heart is finding individuals, treating them, and following them up outside of we'll call it a structure.
Yep.
So that's fine, but I don't, in my view, I don't know if I see, maybe I see it, you know, in my own interpretation, I don't see that as like a full recovery of an addiction. So we have physical buildings that people can go for, we'll say from a process where they go in and they come out clean and now, you know, re-enter the community. So I know Heart offers the here now on the street, but my question was, that's why I kind of directed at Sandy, because you know, she knowing and working in a different element about, you know, do we have enough beds, we'll say, for our population. I've heard conversations where there's could be a deficiency, and so my second question is how many people would have to leave our community to seek that, we'll call it structured addiction treatment.
Okay, and I think, so different language for the same thing, which complicates things, but that's bed-based substance use services that we spoke about, and I think I'll call on any of my colleagues to jump in on this, but what we all believe is that different services meet people's different needs at different times, and I spoke to that in the presentation, that sometimes people may access an outpatient service, they may access a bedded service, they may access both at the same time. It really depends on where they are and what their needs are. And some people, to be honest, most people get their services as outpatients, so in the community, and receive treatment for substance use disorder quite successfully that way. And you heard an example today of the remarkable ability through this initiative in particular to provide quite intensive services to someone in the community that historically, you know, would have only been within the walls of a building. That being said, I think speaking to Talia was talking about a bit of a menu of services, and that's my belief, is that we need, addictions are complex, they're relapsing conditions that continue over time, and we need a myriad of services to meet people's needs. And we do have bed-based substance use services in Niagara. We're fortunate to have a number of them. And that was one of the things that I spoke to earlier in relation to that working group and the work we're doing with Heart around identifying if Heart has somebody that identifies they're interested in a bed-based service, feels like they need it, could benefit from it, that we're working together to figure out how to make that, you know, transition as smooth as possible, how we can stay connected, because transitions are always the most dangerous healthcare intervention, and how we can work together to support folks. When we did the research, when we did participate in the research project, we did find, the project did identify that there were gaps in the services that we have across treatment, supportive treatment, or what we call supportive recovery, and supportive housing. I think we can all speak to the fact that we have a need for more supportive housing in Niagara and beyond. But in relation to the other services, as we've come together and doing our work together, we actually believe that there's a lot more we can do within the services we have to maximize our capacity, to smooth transitions, to collaborate, so that someone can leave one service and go to another. There are circumstances sometimes where people may leave Niagara, and it's an important thing when we think about the healthcare system. They're provincial services, so people may choose to access services anywhere in the province that they desire, and conversely, people may come to Niagara for a specific service, so that does happen. But in relation to serving our own Niagara community, I believe, you know, the group at present believes that we have the ability to do that within the services we have, although we know that we need to improve how we work together to make sure that people transition smoothly from one to the other.
Okay, thank you. Through you, Mr. Chair, thank you for that response. And my concern was that individuals that were going out outreaching and seeking out that service aren't discouraged because there might not be enough capacity. So that was my concern, to make sure that we the community knows that we have adequate. I think that's kind of, I don't know, it's a chicken and the egg thing. It's like housing first or treatment first, but I think they work both hand in hand, and so I think that's, I guess, my concern. That's how I think personally, that's how we should move forward is to let people know that we have enough capacity in the system for them, so that they aren't discouraged or decide that they give up or whatever. So anyways, so thank you for that.
Yeah, and that was one of the messages that the group did want to convey back. So can I say that we're at full capacity? We have as much capacity as we would love? No. Do I think we have the ability to respond to Niagara's needs presently? Yes, although with some of the changes that we talked about. But one of the messages that the group did want to convey, because I think we have a lot of bad press from people's past experiences, is that people don't worry about reaching out and to reach out, make the call, that there are services in Niagara available to support people, and we don't want them to be discouraged from past experiences.
Thank you, Councillor. I have Councillor Olson next.
Thank you, Chair. My question is to do with 7.1. Is that okay?
Yep, go ahead.
Yes, thank you. First of all, I want to ask a question about 7.1, which is the reuniting priority program in the seniors' homes, and that has to do with allocating 4 beds in each home for that purpose of I guess it's reuniting spouses or significant others with their other part. And so I was wondering where those 4 beds come from. Do they affect the waiting list? Is that what they do?
I'll go to Commissioner Koning for that.
Through the chair, thank you for the question. So this is managed through Ontario Health at Home, where they're managing the wait list for long-term care access. They were finding that through placement processes, there weren't sufficient spousal reunification beds available. So they're now reserved for individuals if they're requiring an urgent long-term care bed. So that piece in terms of waitlist management from a need capacity is still inherent in this updated process that supports spousal reunification.
Yes, thank you. I met a man out at the senior showcase who said he was the beneficiary of that process, and very pleased with it, and I guess I am too. So the second part of my question is the incidence of worsened pressure injuries, and that appears to be worsening. Is that because we're getting more people in wheelchairs now, or is that the result of that, or?
Commissioner Koning?
Through the chair, it is related to increasing complexity. So we're finding, because there are more comorbidities in the residents that we're serving, that the incidence of wounds is increasing. They're coming in with more wounds, and the likelihood of developing a wound increases with those comorbidities. They are really looking at work to enhance pressure injury prevention, so that once they're in the home, we don't see the instance of that when we can avoid it at all. If someone goes out to hospital, they're at increased risk because of that transfer out to hospital. Through the homes, they've done significant work to ensure that the mattresses that are being used for residents across the board are pressure-reducing mattresses, ensuring that there's positioning equipment, some automated positioning equipment to support people independently who are sitting in a wheelchair so they can move quickly. As you, I'm sure, are aware, pressure ulcers develop really quickly. So through all those various means, the team's working really hard to mitigate the risk of pressure ulcers.
Thank you, Chair. Thank you.
Thank you, Councillor Olson. I see no other speakers on the list. So I'll call the question to item 7.1 to 7.4. Please vote electronically. Okay. Are you a yes? I'm a yes. Okay. And that carries. Counselor Rigby's a yes as well. Thank you. Okay, we'll go to number 8, other items. Are there any other items of other business? Counselor Bateman?
Thank you, Chair. I'd like to address report CWCD 2026-95. That's appropriate to do it now, as discussed?
Sorry, can you repeat that again? Which one was it?
It was in council correspondence, CWCD 2026-95.
Okay, yes.
Thank you. First, I'd like to just thank Chief Lutz for getting that report. I am still stuck on the fact that we are impacted significantly by our tourism sector, both in wonderful ways and ways that really affect our service levels. So I compared that report, Chair, to other reports. And within the 2026-95, within that report, it stated that there does not appear to be a consistent period where the cost of overtime peaks. While it might not be overtime, I'd just like to flesh that out a little bit. I would kind of hoped, and perhaps I should have been more specific, to see where call volumes happen and talk about how we can address those. Or how we're responding to those, I should say, Chair? Is that something that I could get a staff response on?
Is there anybody that can respond to that? Is there a staff? Yeah.
I can.
If you don't mind providing some information.
Yeah, through you, Chair. The question that was received was specific to overtime, which I responded to appropriately. We did not see a trend in that. We always see increases in call volume in the summer. That has been seasonal. That's something we see and we have seen over the course of many, many years. I'm not sure if there's anything more specific that the counselor would like. If there is, I can certainly look for it and respond to it.
Counselor, is that satisfactory, or are you looking
I
for
just
some?
want to ask a couple questions about that. They're not deep dives or anything like that. Is that okay, Chair?
Sure.
Okay, first, I apologize for having my back to you, Chief Lutz. It feels uncomfortable. But thank you, and I do appreciate that my question was about overtime. How do we deal with such an increase in calls without accumulating overtime in those months?
Are you speaking specific, or through the chair, are you speaking specifically for the tourist area, or I'm not exactly sure?
Not necessarily, just across the region is fine. If across the region is fine.
Okay, through you, Chair. We monitor our call volumes through the day, and so we add ambulances incrementally through the day to address peak call volumes. And that doesn't matter where it is regionally. That's just how we've always done it.
So I'm sorry, Chair, so just to be clear, through you, we're adding ambulances, so we're getting, is that what you said?
So through you, Chair. So let me explain a little bit more. As in a 24-hour day, as call volume increases, we start and stop ambulances that are within our budget. We're not putting more than what we have on at specific hours of the day to address peak call volumes. And so as they ramp up, and we traditionally see them ramp up around 7 o'clock in the morning, all the way through to about 5, 6 o'clock at night, and that's how we address our staffing. We make sure that we have enough ambulances, staff to address those call volumes.
Thank you. And through you, Chair, is that likely adding part-time staffers?
Through you, Chair, no. We don't add additional units. We added budgeted units. The part-time staff are there to backfill our full-time staff. We're a full-time service. They're there to backfill our full-time staff.
Okay, thank you. So I'm not challenging. I just want to make sure I understand. So it's just a matter of arranging the ambulances where they're needed? Is that what you're saying?
Through you, Chair, yes.
Okay. All right. Thank you very much.
Thank you, Councillor Bateman. I have Councillor Olson next.
Thank you, Chair, and I want to say thank you to the to staff for the presentation at the senior seminar. That was their senior showcase today. That was really quite informative and very nice to see our staff there. I've always said we have a superior staff, and it's proven every day to me. One person in the group there was demonstrating a feeding robot today, which was quite a remarkable device on its own, and the operator was able to eat some things, and I saw him eat something as small as an apple seed. So it picked it up and fed him, and he was very happy with it. Described a situation where it gave him dignity because he didn't have to wait for somebody to come and feed him, and he didn't have to make other people wait to be fed. So he didn't feel like he was rushed, and he said it was really an important element of his day. Now he can enjoy a meal just like everybody else. Is there any space in our operating budget to pick up a few more of those? I think that one is at Rappel-J, but I mean.
Well, let's ask Commissioner Koenig if there is.
Yeah. Can you squeeze something more of those into your operating budget?
Through the chair, our operating budget's pretty tight, but we have actually been looking at other funding opportunities that we can tap into to look at purchasing a few more, because we've had really good outcomes, and know we have some residents in some of the other homes who would really benefit from that and who are good candidates from using that technology.
That is music to my ears, Chair. Thank you.
Thank you for those comments, Councillor Olson. I have no other speakers on this, but I will go to Dr. Kuzmani, who would like to provide an update on the hantavirus.
Chair, thank you. And through you, I know that hantavirus has been in the media a lot lately, so I thought it'd be a good opportunity to provide a quick update. As we speak now, I think the Chief Medical Officer of Health is giving an update to medical officers of health around the province as well. So hopefully this isn't too out of date by the time you receive it. But as everybody may have heard, there's a cluster of confirmed and suspected hantavirus cases that have been identified amongst passengers of a cruise ship in the Southern Hemisphere. And hantaviruses are a group of naturally occurring viruses. They infect rodents usually, and rarely they infect humans through contact with their droppings or saliva from these infected rodents. And every year, there's small clusters of cases in South America, Chile, Argentina, and this year's no exception. And so what the current belief is that some passengers who were exposed to a specific strain known as the Andes strain in Argentina then got on this cruise ship and spread it to within very close quarters to other folks on that cruise ship, including people they shared their rooms with. And so just globally, as of May 11th, 9 cases have been reported, including 7 that were lab confirmed and 3 deaths. There are no known cases linked to this outbreak in Canada. And all of the potential contacts, and some of them are very distant contacts. They might be people who I don't think that, I'm unsure, but if there's anyone either on that cruise ship coming back to Canada or through any other means of contact, they've been identified and authorities are following up with them and monitoring them regularly. And so just to be clear, it is a different virus than COVID-19 was, very different situation. The hantavirus, it's not a new virus. And this virus, the information we're getting from Europe is that it has not mutated in any way. We see outbreaks like this that are limited every so often. And the WHO has said at this time it's not considered to have pandemic potential. And so overall, the risk to Ontario and Niagara is low. Again, our team is receiving regular updates. There's other members of the team on the call taking copious notes, including our Associate Medical Officer of Health, Dr. Mogani. And so we're receiving those regular updates from the province. We're currently communicating with healthcare partners on anything that comes up. And internally, we've set up daily meetings just to coordinate amongst us should anything be required of our staff or of us. And we'll keep Council and the Board of Health updated if there are any changes.
Great, thank you, Dr. Guzmani, for updating us on that. I don't see no other speakers on the list. So we'll go to number 9, which is closed session. Does any member wish to go into closed session to discuss a confidential item? Okay, I'm seeing no one. So we'll go directly to number 10. Business arising from closed session items, 10.1, confidential MOH 2-2026. Can I have a mover and seconder for this item? Moved by Councillor Olson, second by Councillor Foster. Any discussion? Seeing none, I'll call the question. Vote electronically, please. And that carries. Thank you. Okay, we'll go number 10 or 11, which is the next meeting will be held on Tuesday, June 9th, 2026, here at 1 p.m. at Council Regional Chambers here at headquarters. This meeting is now adjourned. Thank you very much, everybody.